Let's move on to the fourth epithelial subepithelial corneal dystrophy, and that is the gelatinous drop-like corneal dystrophy. This is a rare but high-yield anterior corneal dystrophy for all of us to know. It is classically associated with amyloid deposition in the epithelium and in the subepithelium space and also in the anterior stroma. A few important high-yield points to remember right away about GDLD are: unlike the previous corneal dystrophies that we discussed, the GDLD is an autosomal recessive condition and it usually presents in the childhood. Moreover, it has been reported most frequently from Japan. Let's discuss the clinical features. Patients here present with photophobia, tearing, recurrent foreign body sensation, and also progressive vision loss. The severity of the symptoms depend on the severity of the deposits. On slit lamp examination, you will see bilaterally symmetrical subepithelial nodules that resemble mulberry-like gelatinous drops. Over time, these can merge, leading to diffuse haze, superficial vascularization, and dense corneal opacity. Another important high yield point here that we need to remember is that vascularization is a very important distinguishing feature here, and advanced disease can also cause amblyopia in GDLD. There are four subtypes of GDLD which have been described mainly in the Japanese literature. These are the band like type, the mulberry type, also known as the classic type, stromal opacity type, and the kumquat type. The band like type of GDLD basically consists of linear superficial opacities across the interpalpebral zone. The mulberry type consists of multiple central subepithelial nodules that look like the mulberry fruit, and these can gradually merge together. Then we have the stromal opacity type. Here you will find a diffuse anterior stromal haze with very fewer nodules compared to the mulberry type. And then we have the kumquat type, where you will have multiple yellowish white nodules, often resembling the tiny oranges. So, tiny oranges in Japanese literature have been referred to as the kumquats. Now let's understand the genetics and the pathogenesis of gelatinous drop-like corneal dystrophy. It is inherited in an autosomal recessive pattern, and many cases are linked to mutations in the TACSTD2 gene, which is basically tumor-associated calcium signal transducer 2. But remember, not all the cases will show this mutation, so there is some sort of genetic heterogeneity, and pathophysiologically this gene will encode an adhesion molecule that helps to maintain the epithelium tight junctions, right? So in GDLD, there will be weakening of these junctions, making the epithelium leaky, and this allows tear components, especially the lactoferrin, to seep into the subepithelial space. And once it's inside, the lactoferrin undergoes abnormal folding and aggregation, forming the amyloid. Over time, these amyloids will deposit and accumulate in the subepithelial and the anterior stromal layers, giving rise to those classic mulberry like nodules. Let's discuss how to diagnose, investigations, and histopathology. The anterior segment OCT here will basically tell you that it is an epithelial and subepithelial dystrophy. So you will find subepithelial and anterior stromal deposits. On histopathology, the hallmark here is the amyloid deposition. On Congo red staining, the deposits will show apple green birefringence under the polarized light. And this is a classic exam point. Now let's talk about an important keyword you will often see with amyloid, and that is the birefringence. Sounds complicated, but it's actually quite simple. Imagine light entering a crystal or a special material. Normally, the light will just travel straight through, but in a birefringent material, the light will split into two rays, each taking a slightly different path and speed. When we stain amyloid with Congo red and look it under the polarized light, this splitting of light creates a unique apple green glow. This green color is a signature that tells us that yes, this is amyloid. So, in short, birefringence just means light is doubled inside the material, and in pathology, that doubling gives us a diagnostic color clue. Now, let's talk about the differentials of the gelatinous drop like corneal dystrophy, because this is an area where examiners love to confuse us. Clinically, the GDLD gives you those mulberry like yellowish subepithelial nodules with amyloid deposition. But what else can look similar? Let's compare. Salzmann nodular degeneration. This is usually seen in middle age or older patients with a history of chronic ocular surface disease. Instead of the mulberry nodules, here you will see bluish white elevated nodules, often in the mid periphery. And histology here shows hyaline material and not amyloid. Okay, and remember, it's a degeneration which is acquired and it is not hereditary like the GDLD. Now, another important differential would be the spheroidal degeneration, also known as the climatic droplet keratopathy. This is seen in the outdoor workers exposed to UV light, and here you get an amber golden oil droplet like deposits in the interpalpebral zone. Okay, now these are again not amyloid, they are proteinaceous and elastotic degeneration. And the key clue over here will be the environmental exposure history and that shiny amber droplet like appearance versus the mulberry nodules of the GDLD. Then we have band shaped keratopathy, which can also you sometimes you might get confused with the band type of GDLD. So this is a calcific degeneration which is associated with chronic inflammation, chronic uveitis, and even systemic hypercalcemia. Okay. Now clinically, this will appear as a gray white horizontal band of opacity across the interpalpebral zone with very tiny Swiss cheese holes. So you'll find those holes in band shaped keratopathy. Histologically, these are nothing but they are calcium and confirmed with the von Cosa stain, and not they are not basically amyloid. All right. So here you think about calcification and not deposits of the um, amyloid protein. Then lattice corneal dystrophy sometimes can also mimic GDLD. This one is slightly tricky because it is also amyloid, but the difference is that um, difference here is basically in the pattern. Lattice dystrophy gives you that refractile branching lines within the anterior stroma, whereas the GDLD gives you those mulberry-like nodules. However, both are Congo red positive, but the morphology is your differentiator. All right. So to summarize, GDLD is autosomal recessive, early onset, mulberry-like nodules, Congo red positive amyloid. Salzmann is bluish white and acquired. Spheroidal is golden with UV exposure. Band shape is calcific, and lattice will show you refractile branching lines. Okay, so that's your high yield differential set. Now let's discuss the treatment part of the GDLD. So, treatment again can be conservative and surgical. Conservative measures include lubricants, supportive care, which can basically help the patient with their symptoms. But most of the cases with GDLD progress over time. Okay, so if you have to remember, among the epithelial corneal dystrophies, the GDLD is something which will eventually progress. So, surgical options would be needed. So, you can carry out a surgical keratectomy or phototherapeutic keratectomy. These can provide temporary visual improvement, but it's important to remember that recurrence is the rule in this dystrophy. Even after penetrating keratoplasty, it carries high recurrence rate, which is why sometimes some people advise that you do a DALK instead of a PKP in cases of GDLD. Now, in rare cases where PKP also fails multiple times and there's recurrent disease affecting the graft, even keratoprosthesis may be considered. All right, so that brings us to the end of this video. Don't forget to subscribe to Insight Ophthalmology for future updates. And if you're interested in joining our memberships for exclusive content, you can find the membership link in the description at the end of the video. Thank you for watching. Have a nice day.